Okay, let's unpack this. Today, we are undertaking kind of a critical deep dive into the metabolic safety nets the human body relies on.
Mm.
You know, those interconnected systems that are supposed to kick in when everything else starts to go wrong.
Hmm.
We're really looking beyond just like single organ failure here
Yeah,
to find those crucial, often invisible mechanisms that keep us alive.
that's right. And we've pulled together some really fascinating material focusing on these complex metabolic scenarios and crucially the danger that happens when two systems we often think about separately, endocrine function and electrolyte balance fail at the same time.
Okay.
We're zeroing in on what happens when the body's own counter-regulatory mechanisms, specifically for glucose and calcium, are basically stripped away.
Right. So our mission today really is to give you, the listener, the shortcut to getting up to speed on some, let's face it, highly nuanced clinical situations.
Yeah, they really are.
Specifically, we're going to distill the surprising and, frankly, often life-threatening risk factors tied to pancreatogenic diabetes, or type 3C.
Mm-hmm.
And then we'll synthesize 4 distinct clinical pathways that lead to dangerous calcium imbalances, always reinforcing that idea that, the clinical context and the underlying disease, they always matter far more than just a single number on a lab sheet.
Absolutely. Context is everything here.
Okay, let's start with type 3C diabetes, then.
Mm.
For most people, I think when they hear diabetes, they think type 1 or type 2, which are, incredibly common.
Right. The big ones.
But type 3C, it's this increasingly recognized category, defined specifically as diabetes that results from pancreatic exocrine disease. So things like severe chronic pancreatitis, cystic fibrosis, maybe hemochromatosis, or even having the pancreas removed, a pancreatectomy.
Exactly.
And the crucial thing, apparently, is that it carries this unique and highly dangerous complication profile, and it's rooted in a missing hormone.
Yeah, we really need to set the scene here for the listener. The pancreas, it's not just one gland, right? It's effectively two functional organs bundled together. You've got the exocrine function, which is all about digestion secreting enzymes like amylase and lipase into the gut to break down food.
Right, the digestive juices.
Exactly. And then you have the endocrine function, managed by these little clusters of cells called the islets of Langerhans. And inside those islets, you have the beta cells making insulin
Mm-hmm.
and the alpha cells making glucagon. And these hormones go straight into the blood.
Okay, so when someone suffers from, say, chronic pancreatitis, which is
Hmm.
basically progressive inflammation and scarring, fibrosis of the pancreas,
Right.
the entire organ is getting destroyed, not just one specific cell type, like in maybe type 1.
Precisely. That's the core pathophysiology. It starts with that chronic inflammatory destruction. The fibrosis, the scarring, sometimes even calcification, it just slowly obliterates the islets.
Okay.
So when you lose the beta cells, well, you get the expected insulin deficiency. That leads to high blood sugar, hyperglycemia, and the patient needs to start taking insulin injections. That part's pretty straightforward, familiar to anyone who understands type 1 diabetes.
But here's where, as you said, it gets really interesting and where the sources really draw this crucial distinction. It's the concomitant loss, the simultaneous loss of the alpha cells that just changes the whole game, that defines the life-threatening risk of type 3C.
That is the absolute key. The alpha cells are the only source of glucagon in the body. And we need to really emphasize what glucagon is in this context. Think of it as the primary rapid response counter-regulatory hormone.
Like the body's emergency brake for low blood sugar.
Exactly. Or like the metabolic police officer carrying the panic button. When your blood sugar starts to fall, maybe you skipped breakfast, maybe you exercised harder than planned, or maybe you just injected a bit too much insulin,
Yeah.
glucagon gets released rapidly, very fast.
And what does that panic button signal the body to do? What's the response?
It signals the liver. The liver is the body's glucose bank, essentially. Glucagon hits the liver and stimulates two key processes. First, hepatic glycogenolysis.
Which is breaking down stored glucose.
Exactly, breaking down stored glycogen into glucose. And second, gluconeogenesis, which is the liver actually creating brand new glucose from other sources, like amino acids.
Okay.
Its entire job is to mobilize glucose immediately to stop blood sugar from dropping too low, to prevent hypoglycemia.
So, okay, let me see if I've got this. If you've destroyed the mechanism that produces insulin, meaning the patient has to rely on external injected insulin,
Right. They're insulin dependent.
and you've simultaneously destroyed the mechanism that produces that emergency fuel response, the glucagon,
Hmm.
You basically created a metabolic trap.
It truly is a trap. And that leads directly to what we call the unopposed insulin problem. In type 3C, the patient has severely impaired or sometimes completely absent ability to mobilize glucose from the liver.
Wow.
So when they inject their replacement insulin, that insulin works completely unopposed by any natural glucagon response. There's no internal endogenous metabolic brake to slow down that fall in blood sugar.
So this means the risk isn't just, occasional low blood sugar. It's rapid, severe hypoglycemia we're talking about.
Yeah.
Severe.
Like drops that could lead to seizure, coma, or worse, much, much faster than you might see in a typical type 1 patient who might still have some residual glucagon function, especially early on.
Exactly right. And this severity is particularly pronounced after periods of, let's call it metabolic stress. A skipped meal, fasting before a procedure, maybe a night where they just didn't eat much.
Mm-hmm.
The external insulin keeps working, keeps driving glucose down, and the liver simply cannot respond effectively to rescue the patient. It's lost its emergency instructions.
Okay. Now, clinically, what should someone look for? We're used to the classic symptoms of low sugar, the sweating, palpitations, tremor, that shaky feeling. How do these patients present differently, if at all?
Well, they certainly experience those recurrent adrenergic and autonomic symptoms you mentioned, the sweating, the heart racing, yes. However, here's a clinical nuance. Because their pancreatic failure is usually a chronic process, and they're often already on insulin therapy.
Right.
Their overall glycemic control, maybe their A1C, might actually be moderate. It might not be terrible.
Oh. This means they often lack the classic symptoms of really high blood sugar, the polyuria, excessive urination, the polydipsia, excessive thirst that we often associate with newly diagnosed or very poorly controlled type 1 or type 2 patients.
So their main red flag isn't high sugar, it's these repeated severe lows.
That's their primary and most urgent clinical marker, that persistent worrying tendency towards severe rapid onset hypoglycemia. That's the signature.
So if a clinician sees a patient who needs insulin, and they have this history of severe recurrent low blood sugar episodes, the big question becomes, is this just, maybe brittle type 1, or is it actually type 3C? How do we tell them apart? Especially since, as you hinted, long-standing type 1 can sometimes also lead to some loss of alpha cell function over many, many years.
The historical and clinical context becomes absolutely paramount here. You have to dig into the patient's history. Are there documented episodes of acute pancreatitis that progress to chronic disease? Is there a history of heavy alcohol use known to damage the pancreas? Are there known structural problems like cysts or tumors? And, of course, if the patient has had pancreatic surgery, like a Whipple procedure or any kind of pancreatic resection, well, the diagnosis is basically confirmed by the anatomy itself.
Okay. But what if the history isn't crystal clear? Maybe the pancreatitis wasn't definitively diagnosed years ago.
Then we look for the absolute signature of exocrine pancreatic failure. This is often the smoking gun.
The digestive enzyme part.
Exactly. Type 3C patients almost universally suffer from exocrine insufficiency. They can't digest food properly because they lack enough amylase and lipase. The clinical result is steatorrhea.
Which is?
Fatty, bulky, often foul-smelling stools because the fat isn't being absorbed. These patients require pancreatic enzyme replacement therapy, or PERT. They take capsules with meals.
Ah, okay.
So if you have a patient with diabetes and they require PERT, you are almost certainly looking at type 3C, regardless of maybe their C-peptide level, which measures residual insulin production.
That makes sense.
Yeah.
Because type 1 is primarily an autoimmune attack on the beta cells,
Right, mostly beta cells.
whereas type 3C is more like a structural demolition of the whole organ, affecting both endocrine and exocrine parts.
You've got it. And that distinction, the simultaneous endocrine and exocrine failure, is precisely why the management implications are so dramatically different. It's not just an insulin problem, it's a total metabolic support issue.
Which logically leads to how we manage it. It can't just be about replacing insulin then.
Absolutely not. The entire management philosophy for type 3C has to revolve around safety and nutrition. Because of that profound glucagon deficiency, we must be extremely conservative with insulin dosing.
Less is more, basically.
Pretty much. We tend to prefer making careful adjustments to basal or long-acting insulin rather than using large boluses of mealtime rapid-acting insulin. Why? Because those big prandial doses are what drive the rapid drops in blood sugar that the body simply cannot counteract.
Okay, and for the learner listening, if there's one really high-yield takeaway from this whole section, it's got to relate back to replacing that missing safety net.
That is the single most critical piece. You must proactively address the missing counterregulation. Every single patient diagnosed with type 3C should be prescribed an emergency glucagon kit. Full stop.
No exception.
No exceptions. Whether it's the traditional injectable form or the newer, maybe less intimidating nasal glucagon sprays, the patient, and importantly their family members or caregivers, must be thoroughly educated on how and when to use it immediately. This isn't optional. It's a life-saving measure against that unopposed insulin effect.
Are there specific diabetes medications we should absolutely avoid in this population? Ones that could make things even worse?
Yes, definitely. We must avoid any drug that could further blunt the body's already weakened response to low blood sugar or independently cause hypoglycemia. Sulfonylureas are a classic example.
Why them specifically?
Because they work by forcing the remaining beta cells, if any, to secrete more insulin, regardless of the glucose level. This can profoundly worsen and deepen hypoglycemia in someone who already can't fight it off. And given the high risk and the rapid nature of these hypoglycemic episodes, aggressive use of continuous glucose monitoring, CGM, is almost mandatory, in my opinion.
That makes sense. It gives an early warning.
Exactly. CGM provides that crucial early warning, allowing the patient or caregiver to intervene with carbohydrates before the glucose drops to a level that causes neurological symptoms. But the core issue always comes back to this. Type 3C diabetes is uniquely dangerous because the loss of the alpha cell has fundamentally crippled the body's primary metabolic safety net against hypoglycemia.
Okay, wow. So we've explored that life or death scenario of the missing glucagon safety mechanism in type 3C. Now let's pivot to another critical system that's also regulated by really fine margins: calcium. If glucagon was the missing hormone, calcium, it seems, is often the misleading lab value. When we look at a standard chemistry panel, we see a total calcium number, but that number just by itself can be profoundly deceptive.
This transition highlights the theme perfectly, the critical importance of context. Calcium is absolutely essential. I mean, for muscle contraction, nerve function, blood clotting, bone health, you name it.
Yeah, fundamental.
But the total amount that you measure in a standard blood test is actually a mixture of different forms, some active, some inactive.
Okay, give us the breakdown then. If total calcium is like, say, the total amount of money you have access to, how is that money actually distributed or held?
That's a great analogy. Let's imagine your total calcium is, say, $10.
Okay.
The first chunk, about 40 to 45%, so $4 to $4.50, is essentially money tied up in investments or bound to plasma proteins in the blood. Overwhelmingly, that protein is albumin.
Oh, okay, albumin.
This albumin-bound fraction is the inactive pool. It's circulating, it's there, but it can't directly participate in immediate biological processes. It's not readily spendable.
Got it. So what's the active part?
Yeah.
The cash.
That's the ionized calcium. This is your cash on hand, ready to spend. It represents about 40 to 55% of the total, so maybe $4 to $5.50 in our analogy. This is the biologically active fraction.
The stuff that actually does the work.
Precisely. It's what interacts with nerve cells, muscle cells, enzymes, and it's the fraction that is incredibly tightly regulated, like second by parathyroid hormone, PCH, and vitamin D.
Okay, so we have bound inactive and ionized active. Is there anything else?
Yeah, there's a small remaining portion, maybe 15% that's complex or loosely bound to small anions like phosphate, bicarbonate, and citrate. This fraction is also generally considered biologically inactive for most practical purposes.
So bottom line, for physiology, for whether someone gets symptoms, it's really only the ionized calcium that truly matters.
Absolutely. If we're asking, is this patient going to have muscle cramps? Are they going to have nerve hyperexcitability? Are there going to be cardiovascular effects from low calcium? We are fundamentally talking about the level of ionized calcium.
Which leads us perfectly to this whole concept of the principle of correction. Why do we spend so much time in clinical medicine calculating a corrected calcium level based on albumin?
Because albumin, being the primary binding protein, its level in the blood can fluctuate wildly based on a whole host of other conditions, things like malnutrition, liver failure, or, as we're about to discuss, certain kidney diseases.
Right.
So if a patient is severely malnourished, for example, and their serum albumin level drops by half, the total calcium measured in the lab will also drop by a predictable amount.
Just because the carrier protein is gone.
Exactly. Even though their PTH system might still be working perfectly fine, keeping the active ionized calcium completely normal.
So the danger is if a clinician just sees that low total calcium number on the report, say 7.5 mg/dL, which looks low.
Yeah, that looks alarming.
But the patient also happens to have low albumin. The clinician might mistakenly rush to treat that low total calcium number with IV calcium or supplements, when in reality, The functional ionized calcium level is perfectly fine. They'd essentially be treating a lab artifact, not a real physiological problem.
That's the trap, precisely. And unnecessarily raising the ionized calcium in a patient whose regulatory system is actually working correctly risks causing iatrogenic hypercalcemia, making the calcium too high, which brings its own set of dangerous complications like kidney stones, confusion, constipation.
So we have to look at the context. Okay, we have to consider the albumin to understand what the total calcium number really means about the functional level.
Absolutely. We must focus on what the patient's clinical context, including their albumin level, is telling us about the true functional ionized state.
Okay, that sets the stage perfectly. Now let's unpack 4 specific, often high-stakes clinical scenarios where calcium levels either too low or too high force the clinician to look past that total number on the page and connect the lab value directly back to the underlying disease process. These are like real-world puzzles that require digging into the system mechanics.
All right, our first scenario is really the classic example of that misleading lab value we just talked about, nephrotic syndrome. This is a kidney disorder, and its defining feature is heavy proteinuria.
Meaning losing a lot of protein in the urine.
A massive amount of protein in the urine, specifically defined as over 3.5 grams per day, just leaking protein through damaged kidney filters.
And since albumin is the most abundant protein in the blood, losing it through that damaged kidney filter inevitably leads to hypoalbuminemia, right? Low serum albumin levels.
Correct. The body is just pouring out its main carrier protein. This, in turn, reduces the size of that protein-bound fraction of calcium. Our money tied up in investments shrinks significantly.
Yeah.
The result, inevitably, is a low measured total calcium value on the standard chemistry panel. The lab report will show hypocalcemia.
But the trap, as we discussed, is that the patient is usually asymptomatic from a calcium perspective. Their actual physiological cash on hand, the ionized calcium, is likely still being managed perfectly well by their PTH system, which doesn't really care about the albumin level directly.
It's often a pure concentration artifact. The total amount is low because the bound part is low, but the active part is fine. And this is precisely why the corrected calcium formula is such a foundational diagnostic tool in internal medicine and especially nephrology.
Mm-hmm.
It allows us to estimate the functional calcium level pretty reliably without always needing the extra hassle and cost of measuring the ionized calcium directly, which requires special blood tubes, specific handling, and often a different lab analyzer.
Okay, let's quickly review that formula again for the listener, maybe make it concrete.
Sure. The most common formula is corrected calcium in mgdl equals the measured total calcium, mgdl, plus 0.8 times the difference between 4.0 and the patient's serum albumin, measured in GDL.
So 4.0 is used as a sort of normal reference albumin level.
Exactly. And the reason we use the factor of 0.8 is based on empirical observations of how much total calcium changes, on average, for every 1 GDL change in albumin. It reflects the typical binding capacity.
So essentially, we're mathematically adding back the calcium that would have been bound if the albumin were normal at 4.0.
That's the idea. Let's use the source example to make it stick. Imagine you have a patient with significant edema, maybe frothy urine, classic signs of nephrotic syndrome. Their lab report comes back, and the measured total calcium is 7.5 milli-GDL.
It's critically low. Panic stations.
Maybe initially. But then you look at their serum albumin, and it's very low, only 2.2 GDL.
Okay.
So we plug it into the formula. First, find the albumin deficit. 4.0 minus 2.2 equals 1.8.
Right.
Then calculate the calcium adjustment. 4K times 1.8 equals 1.44 milli-GDL.
Okay.
Finally, add that adjustment back to the measured calcium. 7.5 plus 1.44 equals 8.94 milli-GDL.
So the corrected calcium is 8.94 milli-GDL, which is maybe low normal, but certainly not critically low like the 7.5 suggested. Huge difference.
A massive difference. And this calculation is strongly supported by the most crucial clinical marker, the absence of neuromuscular hyperexcitability.
Meaning the patient feels fine.
Essentially, yes. If the patient has this low total calcium on paper, but they have no tingling or numbness, paresthesias, especially around the mouth or fingertips, no muscle cramps or spasms, and their Trousseau and Schwastek signs are negative.
Those are the clinical tests for latent tetany, right?
Correct. If those are negative, you can be highly confident that their ionized calcium is actually normal or near normal. The lack of symptoms basically confirms the lab artifact.
Therefore, the management isn't about giving calcium at all.
Absolutely not. Management requires focusing entirely on the primary disease, treating the underlying nephrotic syndrome. That might involve controlling the edema, managing blood pressure, often using RAAS blockade drugs like ACE inhibitors or ARBs to try and reduce the protein loss through the kidneys.
Right.
Calcium replacement is not only unnecessary but potentially harmful if the ionized calcium is normal and the patient is asymptomatic. Giving extra calcium would just push the functional ionized calcium level too high, risking hypercalcemia and its complications. Treat the kidney, not the lab artifact.
Okay, let's pivot now to a different kind of deficit, one that causes true hypocalcemia, often seen in the setting of chronic, severe alcohol use disorder. This is the magnesium problem. This sounds like a classic example of how one critical mineral, magnesium, acts as a sort of gatekeeper or prerequisite for the proper function of another, calcium. The syndrome is specifically called hypomagnesemia-induced hypocalcemia.
Yeah, magnesium or Mg2 plus HAC is really the unsung hero or maybe the often overlooked cofactor in so much of our endocrine system and cellular metabolism. And chronic alcohol misuse causes severe magnesium depletion through really a perfect storm of factors.
Like what?
Well, first, there's often significant malnutrition, just poor dietary intake of magnesium-rich foods. Second, there are increased gastrointestinal losses, maybe due to alcohol-induced gastritis, vomiting, or diarrhea. And third, and crucially, there's increased renal wasting. Alcohol itself acts as a diuretic and specifically increases magnesium excretion by the kidneys.
Wow, so hitting it from all sides. Intake, absorption, and excretion.
Exactly. It's a triple whammy leading to profound magnesium deficiency.
Now, once that magnesium level drops critically low, how does it actually cause the calcium level to fall?
Yeah.
You mentioned a double punch effect that basically shuts down the calcium regulation system.
That's right. The first punch hits the parathyroid glands directly. Magnesium is an essential cofactor for the release or secretion of parathyroid hormone, PTH, from the chief cells in the glands.
Right.
PTH is synthesized and stored, but if magnesium levels are too low, the actual secretory process stalls. The glands essentially go into lockdown mode. So severe hypomagnesemia results in what looks like a functional hypoparathyroidism. You have inappropriately low or even undetectable levels of circulating PTH, even though the calcium is low.
Okay, so that's punch number one, no PTH getting out. What's the second punch?
The second punch hits the target organs where PTH is supposed to work, primarily the bone and the kidney. Severe magnesium deficiency causes PTH resistance at these sites.
Meaning even if some PTH does get released, it doesn't work properly.
Exactly. Even the tiny amount of PTH that might still trickle out cannot activate its receptors effectively on bone cells, osteoclasts, or kidney tubule cells if magnesium is deficient. So the body can't effectively mobilize calcium from the bone reserves, and it can't efficiently reclaim calcium from the urine in the kidney tubules.
Wow. So no PTH signal, and even if there were a signal, the receivers aren't working.
Precisely. The net result is profound, true hypocalcemia that causes real symptoms, the paresthesias, the muscle cramps, potentially even seizures or arrhythmias if severe enough.
Now, this clinical picture, low calcium, low PTH, sounds exactly like primary hypoparathyroidism, where the parathyroid glands themselves have failed, maybe after neck surgery or due to an autoimmune issue. What diagnostic clue helps a clinician distinguish this magnesium-driven problem from actual gland failure?
That's a great question. We look at the serum phosphorus level. Remember, one of PTH's main jobs, besides raising calcium, is to promote phosphorus excretion by the kidneys. So, in true primary hypoparathyroidism, gland failure, you have low PTH activity, which means the kidneys aren't getting rid of phosphorus effectively. The result is typically high phosphorus levels or hyperphosphatemia.
Okay.
But in the hypomagnesemia-induced hypocalcemia scenario, the phosphorus level is usually normal or sometimes even low. Why? Because the underlying cause often involves global malnutrition and renal wasting, which can affect phosphate balance too, but it's not driven by a primary failure of PTH action on phosphate excretion. So, low calcium, low normal PTH, but normal or low phosphorus strongly suggests magnesium deficiency is the culprit. And of course, checking the magnesium level itself is the key differentiator.
Okay, that makes sense. Which brings us to the absolute critical management insight here for the listener. If you encounter a patient with hypocalcemia, especially in the context of chronic alcoholism or other causes of magnesium depletion, you cannot fix the calcium problem by just giving calcium.
It is entirely refractory, meaning unresponsive, to calcium therapy alone.
Ah.
You could literally run IV calcium infusions for days, and the patient's calcium level might transiently bump up a little, but it will inevitably plummet again as soon as the infusion stops.
Why?
Because the underlying metabolic machinery, the PTH release and the PTH responsiveness, is completely jammed due to the lack of magnesium. Magnesium must be replaced first, usually aggressively with IV magnesium sulfate in severe cases.
So you fix the cofactor first.
Exactly. You have to replete the magnesium stores. Until those magnesium levels start to normalize, the PTH release mechanism remains non-functional and the target organs remain resistant. Replacing magnesium effectively unjams the system, allowing PTH secretion to resume and the kidneys and bones to respond appropriately. This then allows the calcium levels to stabilize, often naturally and much more safely. It's a prime example of needing to treat the underlying cofactor deficiency, not just the downstream symptom.
All right, our third context is quite different. It's purely acute, often emergent. We're talking about the setting of massive blood transfusion, typically seen in major trauma, severe hemorrhage during surgery, or maybe ruptured aneurysm.
High acuity situations.
Here, the problem isn't a chronic disease state, but rather a massive, rapid infusion of a chemical preservative that acts almost like a metabolic thief.
Yeah, the thief here is citrate. Citrate is used as an anticoagulant, a chelating agent, added to stored blood products, packed red blood cells, fresh frozen plasma, platelets.
Why is it added?
It works by binding to or chelating ionized calcium. Since calcium is essential for the blood clotting cascade, binding it up prevents the blood from clotting inside the storage bag. It keeps the product liquid.
Okay, that makes sense for storage. But once that preserved blood gets transfused into the patient, that same citrate immediately starts binding to the patient's own circulating ionized calcium.
Precisely. And if you're giving many units of blood product very quickly, like in a massive transfusion protocol, you're infusing a very large load of citrate. This can dramatically decrease the patient's free, active, ionized calcium level.
But doesn't the body have a way to deal with this? It seems like this would happen all the time.
It does. The body has a generally robust safety mechanism. Normally, the liver rapidly metabolizes citrate, converting it primarily into bicarbonate. This process, called citrate clearance, is usually very efficient.
Okay.
So efficient, in fact, that a relatively healthy person can receive several units of blood over a reasonable period without developing significant or symptomatic hypocalcemia. The liver keeps up with the load.
But the key words there are relatively healthy person. The typical patient receiving a massive transfusion, say in the ER after a major accident, is rarely relatively healthy at that moment.
That is the absolute crucial connection. Patients who are in shock, who have massive hemorrhage leading to poor organ perfusion, or who have pre-existing liver dysfunction or acute liver injury or ischemia, all incredibly common scenarios in major trauma or critical illness.
Yeah.
Their citrate clearance capacity is significantly impaired. The liver simply cannot metabolize the infused citrate fast enough.
So the citrate builds up.
It builds up rapidly in the bloodstream, binding more and more ionized calcium at an alarming rate. This dramatically increases the risk of developing sudden, severe, symptomatic hypocalcemia.
And when this happens acutely, we see those really frightening signs of neuromuscular hyperexcitability, right?
Yeah.
Which is basically the nervous system going haywire because there isn't enough calcium to stabilize the nerve membranes.
Exactly. You see a rapid onset of symptoms often starts with paresthesias, that tingling or numbness, particularly characteristically around the mouth, the curieral area, and in the fingertips. Then you can get muscle cramps, increased muscle tone, hyperreflexia, exaggerated reflexes. And the classic signs of latent tetany often become evident. You can elicit Trousseau's sign.
That's the carpal spasm with the blood pressure cuff.
Right. Inflating a blood pressure cuff above systolic pressure for a few minutes induces a spasm of the hand and wrist. And Schwastek's sign, tapping on the facial nerve just in front of the ear, causes twitching of the facial muscles.
Scary stuff.
Very. And in the most severe untreated cases, this acute hypocalcemia can lead to laryngospasm of the vocal cords, causing airway obstruction or even life-threatening cardiac arrhythmias because calcium is critical for cardiac function too.
So management here has to be immediate, right? Often happening right there during the resuscitation while the transfusion is still going on.
Absolutely. This is considered an emergent, potentially life-threatening situation. In many massive transfusion protocols, especially for patients in shock or with known liver issues, we often preemptively administer intravenous calcium.
Even before symptoms develop.
Sometimes, yes, or at the very first sign of symptoms, or based on rapidly dropping ionized calcium levels if they're being monitored frequently. We typically use either calcium gluconate or calcium chloride intravenously.
Is there a difference?
Calcium chloride provides more elemental calcium per vial, but can be more irritating to veins and potentially dangerous if it extravasates. Calcium gluconate is generally preferred unless it's a true cardiac arrest situation. The key is that the protocol often requires frequent, sometimes every 30-60 minutes, monitoring of ionized calcium levels during the ongoing massive transfusion to guide replacement therapy and manage this acute chelation crisis effectively.
So you're basically replacing the cash, the ionized calcium, as fast as the citrate preservative is stealing it.
That's a perfect way to put it. You're trying to stay ahead of the chelation.
Okay, finally, our fourth scenario. We turn to a syndrome that honestly sounds a bit antique, right? Milk alkali syndrome. It dates back to when people were actually told to drink lots of milk and take baking soda for stomach ulcers.
Yeah, the original description was from the early 20th century, related to the SIPI regimen for peptic ulcer disease.
But apparently is making a serious comeback in modern times. Why?
It's highly preventable, yet we see it recurrently, primarily because of the absolutely widespread availability and sometimes overuse of over-the-counter calcium carbonate supplements.
So Tums, Rolaids, that kind of thing.
Exactly. Calcium carbonate is marketed heavily not only for calcium supplementation for bone health, especially in postmenopausal women, but it's also very frequently used as an antacid for heartburn, indigestion, or GERD.
Okay.
And some patients, particularly those suffering from chronic heartburn or maybe drug-induced esophagitis, for instance, from taking oral bisphosphonate pills for osteoporosis, which can be harsh on the esophagus, might end up consuming vast quantities of these calcium carbonate antacids daily, sometimes for prolonged periods.
And it's this chronic excessive ingestion of both calcium and an absorbable alkali, the carbonate part, that creates this specific diagnostic pattern, right? There's a classic triad that every learner needs to memorize.
Absolutely. That triad is the hallmark of milk alkali syndrome.
Hypercalcemia, high serum calcium. That's the obvious consequence of absorbing way too much ingested calcium.
Makes sense.
Number 2, metabolic alkalosis, an increased serum bicarbonate level, making the blood too alkaline. This comes from absorbing the carbonate alkali along with the calcium.
Okay.
Number 3, acute kidney injury, AKI, seen as an elevated serum creatinine level, indicating the kidneys aren't filtering properly.
Hypercalcemia, metabolic alkalosis, and AKI.
Got it. Now, let's spend a minute on the fascinating and frankly kind of vicious cycle that ties this seemingly disparate triad together pathophysiologically. How does it all connect, starting with the high calcium?
Right, the hypercalcemia really kicks off the destructive cycle. High calcium levels have a direct toxic effect on the kidney's blood supply. It causes renal vasoconstriction.
So the blood vessels inside the kidney clamp down. Exactly. They constrict, which reduces blood flow through the glomeruli, the kidney's filters. This rapidly decreases the glomerular filtration rate, or GFR. And a decreased GFR is, by definition, kidney injury, the AKI part of the triad.
Okay, so high calcium hurts kidney blood flow, leading to AKI. But you mentioned it's a cycle. Is the high calcium doing more than just constricting blood vessels? Does it mess with how the kidney handles fluid and salt too?
Yes, absolutely. This is a more subtle but equally important mechanism. High levels of calcium in the blood activate a specific receptor called the calcium sensing receptor, KSR. These receptors are found on the cells lining the thick ascending limb of the loop of Henle in the kidney tubules.
What happens when that receptor gets activated by high calcium?
When the KSR is activated, it sends a signal that inhibits a crucial transport protein called the NOCK-T2CL cotransporter. This transporter is responsible for reabsorbing a lot of salt, and therefore water, back into the body. So, by inhibiting this transporter, the high calcium effectively tells the kidney to waste sodium and chloride and potassium into the urine. This leads to significant salt and water loss, causing or worsening volume depletion.
Wow. So now the patient is hypercalcemic, their kidney function is declining, AKI, and they're becoming profoundly volume depleted because the high calcium is making them lose salt and water. How does that connect to the final piece of the triad, the metabolic alkalosis?
The alkalosis becomes entrenched, mainly because of the kidney's desperate attempt to compensate for that severe volume depletion.
How so?
When the kidney senses the lack of fluid volume, it ramps up the reabsorption of almost everything it can in the proximal tubule to try and hold on to volume. This includes dramatically increasing the reabsorption of bicarbonate, HDO3.
Ah, so it's trying to save water, but it grabs bicarb along with it.
Exactly. Plus, the volume depletion itself strongly stimulates the renin-angiotensin-aldosterone system. Aldosterone further promotes sodium retention, but also hydrogen ion secretion in the distal nephron, which indirectly raises a bicarbonate. Combine this renal bicarbonate retention with the ongoing absorption of alkali, carbonate, from the gut, and you get a profound and sustained metabolic alkalosis.
It really is a vicious, self-perpetuating cycle then. The initial hypercalcemia causes AKI and volume depletion. The volume depletion then causes the kidney to desperately hang on to bicarbonate, trapping the ingested alkali and worsening the alkalosis. And the alkalosis itself might even further impair calcium excretion, locking the patient into the triad.
That's a perfect summary. It just feeds on itself. The hypercalcemia worsens kidney function and causes volume loss. The volume loss drives the alkalosis, and the alkalosis makes it harder to get rid of the excess calcium. This is why management absolutely requires breaking that cycle at multiple points.
Okay, so what are the key management steps? How do you break the cycle?
First and foremost, absolutely crucial, stop the source, stop the intake of calcium and absorbable alkali immediately. Take away the Tums, the calcium supplements, whatever it is.
Obvious, but essential. What's next?
Second, aggressive volume expansion is non-negotiable. These patients are often severely volume depleted. We need to administer intravenous isotonic saline, normal saline, generously to restore their circulating volume, improve renal perfusion, and hopefully increase the GFR. This alone starts to help the kidneys excrete more calcium and bicarbonate.
Okay, fluids first. What about diuretics? I know loop diuretics like furosemide can help get rid of calcium.
That's true, they do enhance urinary calcium excretion by inhibiting calcium reabsorption in the loop of Henle. However, and this is a critical loop diuretic should only be considered after the patient's volume status has been adequately restored with IV fluids.
Wait. Why not give fluids and diuretics together to speed things up?
Because loop diuretics are also potent volume depleters. If you administer them to a patient who is already volume depleted before you've adequately rehydrated them, you will absolutely crash their volume status further, worsen the AKI, potentially causing acute tubular necrosis, and paradoxically make the metabolic alkalosis much, much worse by causing a contraction alkalosis.
Ah, okay. So volume resuscitation first is paramount to protect the kidneys and allow them to start working again. Then once they're fluid replete, you can consider using loop diuretics cautiously to help actively push out the remaining excess calcium.
It's exactly. Volume first, then targeted calcium excretion enhancement if needed. Breaking the cycle requires restoring volume above all else.
Yeah.
#outro. So, if we were to synthesize the main themes from this deep dive today, we've really illuminated two highly specialized and potentially life-threatening metabolic failure points. First, in type 3C diabetes, the major risk isn't just the high blood sugar itself. It's that fundamental immediate loss of counterregulation, the missing glucagon, which transforms necessary insulin therapy into this incredibly dangerous high-wire act with essentially no safety net underneath.
Yeah, that unopposed insulin is a chilling concept. And then the delicate calculus of calcium really teaches us that the clinical context, whether it's the albumin level in nephrotic syndrome, the crucial magnesium status in chronic alcoholism, the sudden presence of citrate from a massive transfusion, or even just a simple supplement overdose in milk alkali syndrome, that context always dictates the true functional state of the biologically active ionized calcium. We learned that just treating the total calcium number on the lab report in isolation is often treating an artifact, or at best, it's missing the root cause of the problem.
It's really a powerful lesson in systemic interconnectedness, isn't it? The integrity of an entire complex pathway like nerve signaling or glucose homeostasis can hinge entirely on the presence and proper function of a single, often overlooked cofactor like magnesium, or the functionality of just one specific cell type like the pancreatic alpha cell.
So what does this all mean for you, the listener? I think we've seen just how critical these seemingly tiny systems or components are to our overall health, and how the body's intended redundancies and safety nets can completely break down when the underlying pathology is comprehensive or hits multiple points at once. It really reminds us that balance in metabolism is truly everything.
And, we've focused intensely today on the immediate, rapid, counter-regulatory functions, glucagon for glucose, p-threonized calcium for calcium homeostasis. These are the fast-acting systems.
Right. Which leads to a final thought, maybe a provocative question for you to ponder after this. Considering how many relatively common conditions, from chronic alcoholism and malnutrition to major trauma requiring transfusions, even just dietary habits and supplement use, can cause these precise, dangerous imbalances we discussed. What other subtle, perhaps slightly slower acting hormonal or chemical feedback loops might be currently misdiagnosed or overlooked in everyday clinical scenarios? Maybe simply because we haven't checked the right cofactor first, or fully considered the patient's complete clinical picture beyond the most obvious lab value.
Mm. It encourages us to keep digging, doesn't it?
It definitely does. We encourage you to keep exploring the why behind the lab values and always remember that sometimes the most dangerous complication isn't the primary disease itself, but the unexpected failure of the safety net that was supposed to catch you.